Good afternoon, everybody. Thank you for joining us this afternoon. Welcome to Health Share Exchange. I'm Bill Marella. I'm VP of Data Analytics and Value-Based Care. I want to introduce our distinguished panel here today, and what we want to talk about is the relationship between community-based organizations and PA Navigate and the healthcare organizations, because I think as we've gotten to know those of you who are working in this space, the thing that's really kind of become most important in my mind is that those relationships are central to the success or failure of this program. And I think there are many examples, including some of the organizations that are joining us here today, that are great examples of where those relationships are working well, where they are mutually beneficial, and where they are serving people and having good effect. So we really want to identify those examples throughout our community and hold them out to people who maybe want to be the next organization to sort of take that step and engage at that level. So let me introduce our panel here. So to my right, Kathy McCarran. You're in the wrong order.
Sorry. Just testing you, Bill.
Yeah. Kathy McCarran, VP of Clinical Programs at Jefferson Health Plan. Nicole Laverty from MANA, the Food as Medicine organization in our region, who's the Chief Operating Officer. Trish Henwood, Executive VP and Chief Clinical Officer at Jefferson Health. And Megan Shreve, who is the Board Chair for Community Action Association of Pennsylvania, who's going to be serving as a subcontractor to Find Help, who is our chosen vendor to support the PA Navigate application. And they're going to be responsible for convening the community-based organizations, or CBOs, with the platform. So let me just say a couple of opening remarks, and then we're going to have some open discussion that I hope you'll participate in. So we have 4 topics that we've all discussed ahead of time, but I would welcome anyone in the audience. For a small enough group that would not be at all disruptive if people want to make comments or ask questions as we go along. So with Secretary Arkush's introduction, I'm not going to spend a great deal of time talking about what PA Navigate is. You've all hopefully heard that. You were probably motivated by that to show up here today. But I want to point out that this platform is already a very robust network of organizations within the state of Pennsylvania. That was partly why we selected Find Help during the request for proposals that we did as the HIEs participating in the consortium. Over the last year, there have been 1.9 million searches for social services on either PA Navigate or some version of Find Help. Many organizations in this room have already been using Find Help, now starting to contract with us to join the PA Navigate Coalition. So all that activity is going to become more robust, more identifiable, and more capable of being married with the clinical data that all the HIEs are marrying today. And as Secretary Arkush pointed out, the importance of doing that is to demonstrate the effectiveness of addressing these social needs for this population. So that will help us demonstrate the effectiveness of the services envisioned under the 1115 waiver. And I think it will ultimately help make social care more sustainable in general by demonstrating that meeting these social needs for people actually has outcomes that go beyond just them and their family. It also saves the healthcare system money. It makes them less likely to get into or create new social needs down the road, and also diseases. So when we look at how this has been playing out in other regions that have been doing this for a little while already, we're seeing people reporting out saving an amount per member per month of anywhere from $85 all the way up to almost $200 when they're dealing with people who have high acuity conditions like hypertension and diabetes. Even just a single benefit like SNAP, we know saves on healthcare costs something to the tune of $1,200 or $1,400 a year. So we have the opportunity to demonstrate the effectiveness of social services at a statewide level, and that's one of the things that we would like to see play out over the next couple of years. So I would like to thank Secretary Arkush and Martin Chikichop in particular at DHS for trusting the HIEs in the state with managing this program and with managing this data. So as Marty pointed out in his introduction, we are already managing a lot of the clinical data around these populations, and being able to marry the social care data with that is going to be particularly powerful, and there are no other states doing this at that level today. So let me talk a little bit about what the long-term vision is. In my mind, in the short term, what I hope we can achieve is greater consistency in our ability to, as a community, to identify these health-related social needs and the people who have them, as well as connecting them with these social care resources. That's the main thing. Part of that is about closing the loop. Part of it is about making sure that when somebody gets referred for one of these interventions, that they actually show up and get engaged. But we also have an opportunity to do proactive outreach to pull people into these programs and identify people proactively who may be qualified for them. We already have a prototype of that activity going now with the Pennsylvania Department of Aging. So we are actively screening for people shortly after they're hospitalized who may qualify for PACE and 18 other benefit programs that they may be eligible for. And with the health system's permission, contacting those people to try to draw them into the PACE screening center. By doing that, we are already connecting people with millions of dollars in benefits every year. And that is what we would like to see scale beyond the 65 and up PACE population to anyone in Pennsylvania that may be in need. Right, and then finally, I think, and this is the overriding concern, is how do we make this program work for everybody? Not just the PA residents, not just the healthcare organizations, but also the community-based organizations. I know many of you are in the room from that part of the sector, so please, we do need your ideas. We would like you to participate in that conversation and help us make this work for you as well. So with that, I'm going to turn things over to our panel and start by asking the first question that we discussed. And maybe before we do that, maybe each of you might like to just take a turn and reintroduce yourself and just say a little bit about what you're doing in this space and how you're addressing these needs currently.
Hi, I'm Kathy McCarran. I'm the VP of Clinical Programs at Jefferson Health Plans for Medicaid, CHIP, and the exchange line of business. I am extremely passionate about this topic, and I'm privileged to lead a division of case managers, and as well as figure out what are the programs that would support the needs of the population that I'm lucky enough to serve. So what is really important is the SDOH, HRSN, whatever the initials are, it is the social needs that the people need addressed first and foremost before you even can connect to the clinical needs. And sometimes that is so hard, and we heard Dr. Akush talk about it, that sometimes the doctors are leery about even asking the question because they don't have the resources. So this is why it's so good that we're here today to talk about Find Help and PA Navigate and how it all will intersect. Thank you.
Hi everyone, my name is Nicole Laverty. I'm the Chief Operations Officer at VANA. Very happy to be here. So VANA is a nonprofit organization here in Philadelphia. We serve across the state of Pennsylvania and in areas in southern New Jersey. We have medically tailored meals that we deliver directly to the clients' homes. We serve a population of individuals who are dealing with critical or serious illnesses. And we also have registered dietitians on staff who provide nutrition education and counseling and support through that. We're also really excited about PA Navigate and the possibility to be able to connect more individuals to our services. I'm sure as most CBOs experience outreach and reaching the people that you know exist who need the services, and the high needs areas that aren't being served is a big undertaking for organizations to do. Also connecting with healthcare providers, We work with HB, so help insurance providers as well, to make sure that this is accessible. It's important. What Secretary Arcu said about the 1115 waiver, that's going to be huge for us, hopefully, and we hope we can help more people, and having PA Navigate to be able to make those connections. And also the data component too would be crucial to our work to be able to show the impact of our program, because that's another area that's really challenging. So we're really excited and hopeful that this will just be able to allow organizations and other CBOs to serve more people and help connect those services.
Thanks. Tricia Ahmed, I'm the Chief Clinical Officer at the Jefferson Health System. I get to work with Kathy as part of the entire enterprise, and get to work with a team across the continuum focused organizationally on health-related social needs. We made a decision. I think we've been having a lot of conversations around the challenges of asking the questions and then what answers we're going to get and how we're going to resource that. We decided we needed to start asking the question, try to best align with resources that we had available, and then think about how we can partner with our CBO partners and with others and with our payers around how we can think about designing programs that are going to address the needs that we've seen. So we did make a commitment to unified screening across our organization starting last spring, initially primary care, and then brought all of our hospital-based environments for all of our admissions online in the fall. So in the course of last year, we've been able to screen 430,000 individuals, and that's been giving us good information in terms of where we're seeing those signals, where we see the need, and then we're working together with our Collaborative for Health Equity, with the plan, with other partners, and thinking about how we can design how we can design more programs to address those needs, and how we can better kind of double click into some of those areas to think about how we can partner. So we're very, very excited about the PA Navigate platform, because one of the areas that we see that big opportunity is more of a loop closure. What are the resources that are available in the community to refer patients to? We've gone through focusing both by the county that they live in and the payer and what programs might be available, and working to align some of our internal programs to support things. But we're really excited to learn more about where we can partner across the continuum as we try to think about our patient population more holistically. A lot of the patients that we see in our hospital environment, for example, are not the patients that we see in our primary care environment, and maybe be seen or served in another system for primary care or lack primary care. And so we're looking to learn more about all of these dynamics among the patients that we're serving, both in our ambulatory and our acute care environment, and then think about how we can connect that all up. So we're really, really thrilled, I think, for the progress and listening to Val give more of the perspective on the state focus, because we believe this is an area where the tide can help all boats rise, and we're really excited to partner again across the whole continuum that HSX brings together, as well as bringing in more of our community-based partners and thinking about how we can solve these challenges together.
Thank you. My name is Megan Shreve. I'm the CEO of South Central Community Action Programs. You might wonder why South Central is here, because I am the chair of the Community Action Association of Pennsylvania. And we are the community engagement partner for Find Health. We're really excited about that opportunity. Community action, which all communities in Pennsylvania have a community action agency, has been partnering with healthcare and has been contracting with many major organizations for a number of years. We've been working on social determinants of health work, anti-poverty work is what we've called it, for 60 years. So we are well versed, very active in our communities, and are really excited about the opportunity to help community-based organizations and healthcare make this a successful implementation. This can be so good for our shared members. Your Medicaid members and patients are our clients. Your dual eligibles are our clients. The more we work together, the better long-term outcome we can have. So really excited about this opportunity.
All right, great. Thank you for that introduction. So let me start with our first question. So I laid out in my opening remarks sort of what our large picture goals are, but I'd like to hear from each of you given what you're doing today and where you see this heading, what would success look like 4 or 5 years from now? How will we know if we accomplished what we set out to do?
So I think from a community-based organization perspective, I think what success would look like for us is just the successful completion of a closed loop referral process. And I say that I worked for Mana for many years, and it takes a lot of work to do that. And I think not one CBO is the same. We all have the different areas we work in. We have different resources, we're different sizes, so there's not really an approach that works across the continuum for all of us. And so my hope is over the next 4 to 5 years that through this process, PNRE is able to identify for the CBOs what works, what doesn't work, what resources are needed to make that closed loop system possible, because I think that's a really crucial part to it. I do agree that, a lot of times what happens, we get the referral, we make the determination if someone qualifies, we set them up with the service. With some of our relationships, we have communication process happening, so the provider knows that, okay, they're set up for services, they're receiving this and so forth, but that isn't always a successful process. And so I think it's really important when we're talking about kind of like the continuum of care, making it full circle, that's a huge component of it, making sure it's successful, they're receiving the service that they need. So I think, that would, having those things figured out for the CBOs across the board and figuring out what resources are needed to help stand them up in that process would be huge. And I think that also, just all across the board, we just want to see that the patients are thriving and getting the services that they need. Yeah.
So, I'll say what I think in 4 to 5 years. I think it'll be like Disney. It will be all together. You'll be able to see everything that a member or a patient needs. And for example, if we refer someone to my buddy here at Mana, the PCP will be able to see that the referral took place. So think about it, that we would all be able to reinforce that same story. So for example, if I referred a diabetic to Mana for the medically tailored meals, they have the dietitian. So then when they go back to the PCP, they could say, so how are those meals working out for you? Do you see how your diet impacts your disease process? Is there anything else that we can do for you? Oh, maybe you need to be hooked up with how to make the meals once the Mana meals are finished. But I mean, it's just opens that everybody is providing whole-centered care for the member because we're all know the same story. That's how I see the beauty of this in 4 to 5 years.
I think building upon those points exactly the same, the opportunity for really that integrated approach. I think we are component parts working on different aspects of this sort of continuum, but they're not connected. And so I think the opportunity to think about connecting that is very exciting. I think we, in healthcare, at least in healthcare improvement, we think a lot about the quintupling. Historically, there was the triple E around population health and care experience and cost. The value proposition that's since evolved to consider things like health equity as well as clinician well-being. And I think this is an opportunity where we know that our clinicians want to be doing the right thing for our patients, right? And this is where we thought long and hard in terms of bringing on screening, where we didn't have as many robust options as we would have liked at the time that we launched the unified screening, but we knew that getting the information to figure out where those needs were the highest was going to help us align and prioritize. So I think we see this as something that's going to contribute to our physicians and our APCs and our clinical teams when they're providing care and feeling like they're able to connect the patient. We see that it's something that's going to help our patients and families, that it's something that's going to drive outcomes and something that can help us with the cost proposition. So I think it is very exciting if we can get the Disney model together, as Kathy mentioned, in really connecting the dots, and I think where our patients, our community, and our organizations will all benefit.
And building on those answers, I think it's a given that our clients, your members, and patients, that their lives are improved. I think that should just be a standard part of it. I think that community-based organizations hopefully have the supports to close the loop in the way that we need to. I think, again, that's a given. Those should be obvious solutions that come out of PA Navigate. But I also think that the data that we get from PA Navigate will be invaluable. So, for example, in most communities, 1 out of 5 income-eligible families will only get a voucher, a housing choice voucher, 1 in 5. The other 4 who are income-eligible will never get a voucher. What happens to those folks? This data to show what exactly exists in the social support system and what do we do about it will be really important. Or if you were referring a client to a food pantry who's already going to a food pantry, what does that mean? If a family's only getting 4 days of support from a food pantry, is that adequate? So I think we'll be able to get data that shows that the social support system may not be adequate, but we'll be able to have the data to show when we can support someone adequately, the cost savings are there, which changes the social support system from a spend to an investment.
All right, great examples from everybody. And so Megan, your comments just now kind of reminded me of something else I wanted to talk about. You know, a lot of us are monitoring, or trying to work on approaches to monitor for health equity and equitable distribution of resources. And that applies to the social care as well. And what we're seeing right now, we're just kind of scratching the surface, but we're already looking at data showing that when we look at the population of people who are both food insecure, living in a food desert, and low income, the distribution of food pantries looks fairly uniform in just the 5-county area, but there are several zip codes. The average zip code has about 650 people likely in need that are being served by their food pantries. There are some zip codes where the population in need is 10 times that per pantry. So there is definitely a mismatch between where the needs are and where the people are. And I think that's another thing that we have the ability to correct over time. I think that's part of what the state is hoping to get out of this, is to see that every area of the state where there are people in need are able to get these services if we can get them to engage with them. You also touched on the next question, actually, which is how are you using data today to inform what you're already doing, and how do you see that changing in the future?
I guess I can answer since I have mic. So we are, as I mentioned, now almost a year into the primary care screening, so we're looking forward. That's an annual screening in our primary care context. In our hospital environment, we're looking for admission. We're interested to see, as we see patients again continuing to move through, are we able to see that their needs were addressed based on the resources that we had available, or our efforts to address them at the time of the annual screening. So we're going to be continuing to track that as we again move through another year and re-screening those patients and seeing if we were able to close gaps or gaps widening, where we're effective or not. We're certainly working on, again, those areas where we're seeing opportunities and where we can align some more of our programs. Our organization is quite large and has had a lot of programs in a lot of different aspects of the health system, but thinking about where we can pull them together and then prioritize some of the focus based on the needs that we're seeing emerging. So really looking at that data as an opportunity to kind of listen and learn from our patients on how we can align programs from there. I think where we see it moving forward is having more of those connection points in terms of the opportunities to plug people in with willing partners, and getting that loop closure is really going to help us again see how that's impacting outcomes, where we anticipate also continuing to dive into the data deeper and link it to some of our outcomes information, again, as we have more data over time and following patients. So we're really excited to connect it to the continuum where possible and where we're going.
Because we've been doing kind of this social determinant of health work for a very long time, we've been doing screenings. Really, we thought about them as achieving economic security, long-term stability. So for community action, we have a large number of programs. We're trying to broker those programs for the best outcome of the families that we serve. So that part of the work we're already doing. I would say there are two things that have been exciting about that is having the system level work informed by the work that we're doing with families. So what are we finding? How much money is available for food? How many housing vouchers are there? How do we look at this from a perspective of making change in the community? And the second thing I'd say, because we're getting referrals now, especially from behavioral health managed care, most of our community action agencies have contacts with them, it's been really interesting to see how this work is stabilizing someone's mental health and the small pieces that are, let me give you, I'm going to give you two examples. One, we had a referral from a therapist to one of our offices. An individual had a housing choice voucher, which is gold, especially if you have someone who has significant issues, that enables them to be stable, right? But her son, who has significant behavioral health issues, broke a window. And so they're facing eviction for about a $600 window. Well, I don't have funding to fix windows. Like, it doesn't, in social services work, we don't have that. But we could work with our managed care partner to say, look, this $600 investment keeps your family stable. And so working that out in order to do it, we always rely on the services that we currently have in order to help our healthcare referrals. So whatever programs we already have, we're going to use that funding. But if we don't have funding, it's been really helpful to be able to get additional contingency funds. We kind of think of them. We had another individual on the autism spectrum, again, a referral by a therapist. This individual's long-term stability, the therapist felt, was being impacted by the home structure that he was living in. And they thought it would be better if he could get somewhere stable. They were able to help find housing. He needed a security deposit. Well, in the homeless world, when you are looking to help with rent or a security deposit, someone has to be literally homeless. This individual is not literally homeless. So I couldn't make them eligible in any way. But because we were able to work with our healthcare partner, like, we can help with all of the other pieces, but this piece, we were able to get that security deposit, which enabled them to do it. Kind of in a roundabout way for contingency funds. So it's really interesting as you think about this, the ways that we're able to partner together and be able to use those screenings to actually have long-term beneficial outcomes.
I think it's no surprise that CBO's data is very challenging. So at MANA, referrals are sent mostly directly from medical care providers. We also have our contracts with our insurance partners, so it's coming from care coordinators or other entities like that. And so they provide limited medical information on the referral form, which helps us to determine eligibility. It helps our dietitians screen for nutritional risk and providing nutrition counseling and education. It informs, our program as far as who we're serving. We have different diet modifications, so making sure that they're meeting the needs of the population that we're serving. A lot of the data that we collect comes directly from the clients that we're serving, which is very informative and very helpful for informing our program, growing it over time. We got a lot of feedback about one client choice, so we're actually going through a huge technology acceleration program to start implementing that in the next couple of years, which is great. But what we would love to have more access to is more robust data to really show the impact of our program. To show how outside of, we're sending food, we stabilize their health situation, and now the person's no longer on our program, which is great. But having access to that more robust data can help to better tell our story, to help us help our people grow our program, make more partnerships. Obviously, funding opportunities would be huge. So that's what I'm really excited about with this, with PA Navigate, is the ability to not only share data, but also get data back that can help grow and enhance our services.
Thanks. So what I see from our point of view is we definitely know the data on our side. Some of my buddies are here today, and we definitely know the data, calling out Marlene here. But we understand the claims data, and we understand the SDOH data if it comes over on the claims. But that's not coming in fast and furious as we would like. We also know based on assessments of our members, but that's on an individual basis. We understand through assessment that they are food insecure, or they need medically tailored meals, or they need transportation support, or they need lie heap services. But again, it's on an individual basis. Our health risk assessment, the same story. It's only for the folks that fill out the assessment. What I see on this side is a more robust understanding of the specific zip codes, all the support services at these specific zip codes, and what we could do to partner in those areas. Because again, it's providing the resources in the community for the members we serve.
All right, great, thank you. So let me encourage the audience to please, participate in the conversation. I'm going to bring up what I think will probably be our last topic based on the time. But many of you are going to have opinions about the same thing, so I'd encourage you to please speak up or ask a question if you choose to. So this is the key question that I started with, which is, if you were to talk to a community-based organization that maybe doesn't have any contracts currently with a healthcare organization, a health plan, or a provider, or if you were to have a conversation with a healthcare organization that has not really engaged with the CBOs in their area other than to just make referrals, what would you say to them about how you go about creating a mutually beneficial relationship that sort of approaches what I think many of you are doing already together?
So I have this, and this is an easy one for me. I think what's really important, if I can use the experience of our relationship with Anna, it's just communicating. It's just having the conversation. It's not overwhelming each other with the acronyms, because as a managed care organization, we love them. And then we also don't talk, we have abbreviations, we have lingo, so we have to make sure that we are open and we understand each other. Also, it's just to understand and talk back and forth, like what does the CBO offer to the managed care, so that the managed care can understand how this impacts us as well. Because we're always trying to steer folks to the correct utilization, meeting their social needs, and decreasing inappropriate utilization. So, as well as addressing the disease condition. So that, using the MANA example, it's really a clear conversation that, oh, we have diabetics. Oh, you have medically tailored meals that would suit these diabetics. This could potentially reduce HbA1cs, keep people out of the ER, keep them out of a hospitalization, and potentially push them back to the PCP because of all the education and ongoing case management. But again, it's open communication and really making sure you understand each other.
I'll piggyback off that. Yeah, JHP was our first insurance contract, and they were a dream to work with because they gave us a seat at the table. They allowed us to have the conversations. They learned about our organization, the impact we can have. We worked together to figure out the first population to work with, how the referral process would work, how the sharing of data back and forth could look like, and it was, although I would say it was a big lift for MANA, it was a lot of work. It continues to be, just as we grow and expand our services. But they made it easy, and were truly partners of ours, so that was really helpful. And also allows the opportunity to, we started with type 2 diabetes, but we've expanded to many other disease states. We've also had opportunities to test out different programming, like a discharge process where people were discharged from the hospital, got 4 weeks of a service to help reduce readmission. We feel like that's a huge area that MANA could grow into and have a really big impact on the health of others. And so, yeah, I think just the communication aspect is really huge, and just giving us the opportunity over time to grow together too and continue to have those conversations.
I think just to continue that thread on communication and understanding where each other is coming from. I think when I was talking with Bill and Marty on this, for us as a health system, understanding where a CBO might have their funding source or what metrics or, where they need to manage to, right? I think a lot of times we have the same goals, but to Kathy's point, we have to make sure we're not speaking different languages in terms of the lingo. I think at the end of the day, we're trying to do the right thing for our community members or our patients or our members of the plan, and trying to think about how we can connect that up and understanding what are some of those background drivers that you have to manage to, so that we can think about how can we work this so that it works for the metrics that you need to deliver for, again, your grants or your philanthropic sources or whatever it may be, depending on the size of an organization. and what we need to, think about delivering on for our patients. I think we have, on the system side, hundreds and hundreds of, programs and metrics depending on what that program may be, but I think understanding where our partner may have the focus and how we can find the right synergies together. And I think, speaking on behalf of our system, I think it's just the openness, anyone's interested, reach out. We want to have those conversations. We understand where you're coming from, what your capacity is, how we can work together, but not overwhelm in terms of, I think you find a great partner and then you're like, okay, and then we want to make sure that we make it sustainable for those partners too. So I think just the dialogue is so critical and understanding where each other are coming from so we can find the right place to meet in the middle.
Yeah, I would agree with all of those points. I think what we've had some great success with is having our, both our providers, so some of our healthcare systems and hospitals have come to visit, as well as our managed care organizations and insurance companies have come to visit, which has been great for them to get a feel of actually what goes on. We're really trusted partners in the community, and helping them understand that has been really valuable. And what I would say for community-based organizations is, first, don't say yes just because it's money. You have to understand what you're agreeing to. You have to contract well. You have to say no if this isn't in your wheelhouse. Don't follow. This is not the place to follow money. So we negotiated contracts. If you can't do the work or you can't measure the work, don't do the work. And so we internally in our community action agencies have been doing a lot of work on this, as well as the communication aspect. So better understanding, healthcare speak. And working with our partners so they understand our lingo as well. And then I think there's this other piece for small nonprofits that are critical in the ecosystem of a community. So they may be serving very targeted populations, we are trying to figure out, because we have lots of partners like that, they may be serving the Haitian community so well that we want to figure out how to make sure that they have appropriate support to continue doing their work. How do we set that up? Is there a way that there can be, whether it's a larger nonprofit or somebody with the fiscal infrastructure can support that? So I think there's a lot of pieces around the eco kind of system that exists that are really important. And the one thing I would say to healthcare is, nonprofits have been working in communities for a long time. We know the community, we are trusted partners. And if you go in and recreate nonprofit programming, you will, and there's times when it's appropriate to disrupt, right? We all know that. But if you disrupt the ecosystem, you can't do it well. Like, I would never practice medicine, right? So just be thoughtful in that. If you go into a community, disrupt the ecosystem, nonprofits go away. If you can't do it well, you'll pull out, and the clients will be blamed. And we can't do that.
Dwight McBee, Jefferson Health, and this is for anyone, but certainly for Megan, as we think about CBOs. I love your comments about the smaller CBOs. We have to think about them as critical in this whole ecosystem. And so from your perspective, what are some of the themes around their needs? Is it sort of administrative? What are some of the things we should be thinking about as we think about moving toward PA Navigate? Because we want them to grow as well, right? We don't want them to, although they're small now, we want them to mature as we're all maturing. So what are some of the things that you're seeing from your perspective, or things that we should be thinking about as health systems as we begin to go down this path?
Yeah, so when you think about food pantries, that's going to be a really good example, because many of the food pantries that we talk about that are in outlying areas are in churches, and they're run by volunteers. And it could be that 86-year-old woman who this is her calling, right? So do they have any IT infrastructure? No. Do they have internet in the church? No. So we have to figure those pieces out. So entities that work with the state food program, we already work in the county with 6 other smaller community-based organizations, those, volunteer ones. And so thinking about it from their perspective, is it better that we have internet there? Is it better that paper comes to us and we fill it out like what we're doing now? What is the best? And then working from that perspective. And I think the benefit of working with community-based organizations is that we're in a community. So we can kind of help navigate those pieces. And I think it's just important for insurance companies or for payers to think about, so because I'm working with those 6 pantries, the money doesn't come to me, right? We have to be clear. So just because I may be doing some of the administrative functions, maybe some administrative roles, we need to make sure funding gets to those entities, either for infrastructure or if they need to have now not just volunteers because their referral base is increasing so much.
Hi, thank you very much for your comments today. My name is Jim Bueller. I'm at Drexel and former board member in somewhat distant past of HSX. In thinking about the uses that I hear you envisioning from having access to this type of data, these types of data, particularly from the CBO perspective, just having the data is a requisite first step, but that's not enough. You need the capacity to effectively use that data, to manage it, to access it, to analyze it, to understand its strengths and limits, to be able to apply it to improving the management of your programs or to evaluating them. And I'd be curious, particularly from the perspective of the CBO representatives, what type of infrastructure would you see as necessary in order to support you and perhaps some others that may not have the level of capacity that you have to really take effective advantage of these data in the way that you've envisioned?
I do think that's the complexity, that community-based organizations come in all sizes, in all levels of sophistication. So, for instance, our organization is, last year we were $24 million with some CARES funding. We work with software systems that the state controls already, so we're getting data, we're doing continuous improvement, we're making changes in the community. But those mom and pop community, smaller entities may not be doing that, and we are doing some of that because they operate in some capacity under our umbrella. But I think we're going to have to work at that community-based organization by community-based organization, and figuring out, do they have the right security in place? And if they don't, then what does that look like? Either do we implement that there, or is there a community hub that starts to standardize the data, use the data, do the analysis, and then work with our partners? I think this is all of the work of this implementation. The software is one thing, it's really the success is the implementation. How do we take thoughtful action? Part of the reason the Community Action Association of Pennsylvania wanted to be in this role is to bring the voice of community-based organizations, because if we don't have their voice at the table, this can't be successful, right? And so let's figure this out together. And I think our partners like you, will be instrumental in that piece.
Yes.
So I have a big mouth, so I'm fine. So my husband says it often. So I'm just sitting here. I come from a managed care space, and now I'm at a mid-sized nonprofit. We have housing, a food market, everything. When I'm looking at value, quality, access, and connection, I am so over data. I just personally, we have so much data. You have MAN and you have this organization who are CBOs that are contracted with these folks, right? My heart is the person that we're serving. This data is great, all this stuff is great, but my issue is, like this young lady said, that I see them 1 year, we're gonna refer them. What is gonna happen to that person in a year? How are we going to share data and we're not contracted? A CBO who's not contracted. And my issue is, I feel like it's just so much data, and implementation and measurable outcomes are not what we hear. We hear the data, we know where the places are, we know where the disparities are, we know that very disadvantaged organizations and some of the hospital systems may not be able to serve them. But sitting here listening to all this, my concern is the individual, right? If we are referring to an organization like mine who may not be contracted, how are we gonna know that person is gonna get housing if they're homeless, right? We can be on the exchange, but where is the implementation? Who is going to be the mediator between the exchange and the people that they're seeing that week, right? I work with MAN, I love MAN. I know that our moms who were pregnant, we could call them and say, yeah, this is what they do. But if an organization is like mine, who are just in the cut, with a very high population of the social determinants for everything, how is exchange really going to be able to see measurable outcomes? I don't want to wait in Disney in 5 years. I want to know within 2.5 years that when this information has been exchanged to a lot of folks, that somebody got home, somebody got a house, there was right food for those people. So for me, I'm just trying to figure out, and I'm not upset or nothing, it's just that I go to so many, I'm on the chip board, I sit in a lot of MAC meetings, I hear about all this stuff that's going on, and I know that the state is still trying to find, and you all may have the answer. but realistically, how we're gonna really know and be able to exchange to know that person that's coming into the doctor who is homeless, that they may get their house before that next year. So I don't mean to be the bearer of bad news sometimes, but it's just that because we're still having moms lose their babies. We're still having people that are sick. We still have diabetics not seeing all 5 of their doctors. So after all the data is there, and after all of this exchange is there, when can we completely say, we're gonna look at this data maybe in a year or 2 years and say, this family's life has been impacted because this is what we're giving them access to?
Seriously, we should give her applause. What I would say though, right, you know that they got housed, right? You know what's happened to that family.
Got it.
Right, we, community-based organizations, are collecting so much data on the successes and outcomes of the clients we see, and know all the work that went into getting that there.
Yes.
Frequently, it's in either a homeless information management system or some other system that the state requires that we use that really should be integrated with PA Navigate, because this is state system data that already exists where the outcomes are already in there instead of just expecting that that's going to be closed. But I think those are the voices that, as we work on this, are critical to the process, right? And I think it's really important for healthcare to understand we have lots of measurable outcomes. We collect a lot of data, put it in a lot of systems, we know our successes, and there is this myth that we don't, which is so crazy. We have very sophisticated processes, we are great with the payers we serve, we see amazing long-term outcomes. Just like you do, we just don't see yours, you don't see ours, right? We hope that through this process that can change.
No, I know you do. Let me go back. I know that a lot of people, I've worked with MANA. I know how our members were changed. I know how they were impacted. I know they were visiting the houses, but these are people who are contracted. I may not need to be contracted, right? But what I'm saying is I'm not contracted. How am I, as a CBO who's accountable to that person along with you, going to be able to exchange the information with Jefferson and say, hey, thank you for referring me, but this is what's going on with the past, because we can't exchange with so much information. So that is the part that I'm trying to see, how do we fit that piece in for those who are not contracted, and we want to also exchange that information too.
And I would say, is it that you don't want to be contracted?
Oh, we can always do that,
Okay.
but I want to be realistic
Let's
to
talk
everybody
that.
wants.
Let's talk
Got
that.
it.
I would love to talk to you.
I think it's an opportunity, just speaking as an agency board member for a moment, for some of the mapping, right, around the data in aggregate, or the most common areas that things are already going to the state, right, and hearing the Secretary's comments in terms of the focus. One, I think the focus on the 1115 waiver and the opportunities that will provide in terms of a further funding source that we're all challenged on, how we support people in navigating. But thinking about, are there other data sources that we need to think about how we might link up to get more of that loop closure more effectively, recognizing some of the various challenges with data infrastructure. And I mean, I have to call out, right, we live in a cybersecurity challenged world too, right? And we've seen recent major data breaches in healthcare. It's something that we have to think very closely about in terms of how we link up, right? And so I think mapping some of that together with you all will be a great opportunity to think of where are some of those areas that, with this being a state level program, we can think about linking up more effectively so that we're not duplicating efforts for anyone. And again, we can bring that focus to that individual patient. I think same thing from our perspective, right? There's a million metrics we have to manage to, but we are managing to every single day the patient that we're delivering care for, and or their context at that moment. And so I think we all have that focus, and we find ways to connect those dots to make it easier for us to communicate and collaborate.
All right. Well, thank you for that challenge, and I hope we will have a more concrete answer for you next year at this meeting.